All right. So today's topic is substance use disorders. One other quick announcement before we get into it. So about the quiz questions that I was talking about yesterday, we did make one of them a bonus question. It was the one where you had to decide what medication to pick for a person that has generalized anxiety disorder. And while I said bupropion is not indicated for GAD at all, which it's not, and so it's definitely a wrong answer, what I kind of forgot that I told you guys was only memorize the FDA-approved indications on the pre-lecture worksheets. And so because I told you that, I don't want to mess anybody up. So we turned it into a bonus question because citalopram is the right answer. And so if you did pick that answer, you should get awarded for that. Except that citalopram doesn't have an FDA-approved indication for generalized anxiety disorder. It's just widely used for generalized anxiety disorder. And so it was the right answer. It's just because I told you guys not to memorize that, like the FDA-approved or off-label indications. I don't want to, hurt anybody's grades for that reason. Does that make sense to everybody? Moving forward, I'll try to really only include for the midterm exam questions that I specifically had you guys memorize instead of stuff that I think happens. Any other questions before we get into substance use disorders or questions on the pre-lecture material? Okay. So here is the session ID for Turning Point. Does everybody have it? Okay. So there's a lot of suggested reading. There are 2 chapters from DePiro, the first one on alcohol use disorder and the second one on opioid use disorder. Then I have posted on Blackboard kind of a lot of extra stuff. This is my area of expertise. This is what I do every day at MGH, so I have a lot of stuff on this. There's a clinical pearls folder. That stuff is testable material. The supplemental materials folder is not testable material. It's just if you're kind of interested or you want to learn more about it. So there is a paper that was published last year, on addiction as a brain disease, and it really goes through and it tells you all of the things that have been messed up in the brain of somebody who has a substance use disorder, really trying to underline the fact that addiction is in fact a brain disease. It's not a choice. It's not something that people just decide one day, I'm going to be homeless living on the streets shooting up heroin. Nobody aspires to be that way, and it's not something that they decided to do. So that paper really, if you're really struggling to understand addiction as a brain disease, I really recommend reading that paper because it really highlights all of the pathways that have been kind of hijacked throughout the brain. And then I also posted on Blackboard, it's kind of like a white paper, it's like an essay kind of, on the effects of chronic alcohol use, just to give you an idea of really what chronic alcohol use does throughout the entire body. So the pre-lecture material covered a little bit of a lot of the objectives, and then we'll get much more in depth today. So by the end of, after listening to the pre-lecture material and today, you'll be able to explain the pathogenesis and diagnostic criteria of alcohol withdrawal syndrome, which is abbreviated AWS, alcohol use disorder, or AUD, opioid use disorder, or OUD, and opioid overdose. You'll be able to summarize signs and symptoms of alcohol and opioid intoxication and withdrawal. You'll be able to recall substance use disorder medication, mechanisms of action, adverse effects, drug-drug interactions, monitoring parameters, counseling points, and dosing, but only if it's specified. I tried to highlight when I don't care if you know doses versus if I do care. You'll also be able to recommend patient-specific pharmacotherapy regimens for people who are withdrawing from alcohol, people who have alcohol or opioid use disorder for maintenance treatment, and people who have been victims of an opioid overdose. And then finally, you'll also be able to recall principles, it's supposed to be plural, principles of harm reduction and list harm reduction initiatives. If you guys downloaded the pre-lecture material like more than a week ago, I did have different objectives, but they were all over the place, so I updated them, and these reflect the current objectives, and I've also updated the new slides, so if you guys just downloaded the new slides like yesterday, it's up to date. I updated it like 5 days ago. Okay, so we'll do a couple questions on the pre-lecture material. First one, true or false? Addiction is somewhat like a chronic disease because dysfunction in the brain pathway is involved. However, it's considered something separate because it involves the choice to use a substance. Just tell me. False? How come? Because it's not a choice. I really want to talk about this a little bit because I know you guys did a little bit of stigma stuff in seminar, but this is a little bit different. Does anybody kind of struggle with that? Because this usually comes up a lot. I've taught large audiences in this subject kind of across the United States at this point. And there's a lot of times, like pharmacists, currently active pharmacists, physicians, like really struggle with accepting that addictions are not a choice. So I would really kind of like to open this up for a little bit of discussion if anybody's struggling with that concept, and we can talk about it and try to get down to really what it really is. So does anybody have questions? Go for it. Mm-hmm. Yep. Yep. So really good question. The question is, well, what about the first time? There's definitely a choice involved in the first time you pick up something, right? So yes and no, and it depends. We covered risk factors, right, in the pre-lecture material. So there are a lot of risk factors for somebody deciding to use a substance for the first time. If you think about it, somebody who's growing up in an inner city who doesn't have a lot of access to a lot of opportunities, whose parents have been using heroin their whole life, and so that's like all the kid knows maybe. Maybe he's like 11, and he sees people out on the streets that are dealing drugs, so that's all he knows how to make money. Is it really a choice when he ends up deciding to use? Maybe. I mean, sort of. There's definitely a choice involved in picking up. But also always needing to think about the cultural influences on the person's actual action of using for that first time. Really good question. What else? The other thing to think about is, like I've smoked a cigarette before. I've drank alcohol before. But I'm not addicted to any of those things, and it's because I'm not displaying the signs of addiction. I don't smoke now. I haven't smoked a cigarette since the first time I did it, because that was gross. But I didn't get addicted that first time, right? I chose to do it, but I didn't get addicted. I choose to have a glass of wine a couple times a week, maybe, but I don't get addicted. And that's just because I have a lot of protective factors. I don't have as many risk factors, but also my brain doesn't have that switch. Right? So the thing to remember is that people's brains who end up getting addicted to things are already hardwired because of a variety of reasons. A lot of it's genetic loading, but a lot of it's their environmental surroundings. But their brains kind of like have a switch. It's like a light switch. And it's almost like the first time they use that. You'll hear people when they talk about when they first started using opioids, like the first time they took a Vicodin, everything was like amazing and better. I've had surgery before. I've taken Vicodin. I fell asleep. That was it. It was it. I woke up and I was like, okay, that's it. Moving on. You know, I have pills left over at the end of a prescription if that happens, and I dispose of them appropriately. But so that's because for some reason I got lucky, and my brain hopefully doesn't ever acquire that switch, but it doesn't have that switch. But that doesn't mean that everybody's brain doesn't have that switch. And people are just predisposed for a variety of reasons. How about any other questions or anything else that you struggle with? Okay. So this gets kind of back to what we were just talking about. There's a big thing. A lot of people always kind of say, well, why can't they just stop? You know, you picked up that first time. Why can't you just put it down and walk away from it? So thinking about it, like, I always parallel addiction to diabetes because they go their pathways are kind of similar. So somebody in type 2 diabetes specifically. So type 2 diabetes, you have a genetic predisposition to get it. It is a disease. It's oftentimes a result of, we call it social determinants of health. So people who don't have the means to eat nutritious foods and exercise every day and all of those things are more likely to get diabetes. It's the same for addiction. The other thing that happens with diabetes is once you get it, you have it for the rest of your life. It's the same with addiction. So it's chronic. It does progress if you don't take care of it. You can start getting, you can lose limbs, you can lose your eyesight, eventually die, get kidney disease, all that bad stuff. Addiction's also progressive. The more you do it, the worse it gets. You get a whole bunch of complications, which I think I covered a little bit in the pre-lecture. We'll cover it more today, maybe. Whole lot of complications, and you can die from it. So it is also potentially fatal. So it really parallels other types of chronic illnesses. In addiction, the brain is hijacked. In diabetes, let's call it the pancreas is hijacked. Okay? So the organ is hijacked, and it's messing up. It's not doing the thing that it's supposed to be doing. So there are 3 stages to that hijacked part of the brain in addiction. The first is binge and intoxication. So that's like thinking of the first time you used. The first time you guys ever had 2 or 3 or 10 shots of tequila, right? So that's a binge. And you got drunk. If you never have, don't worry, that's fine. But if you have, you know what that experience was like. Maybe some fun things happened. Maybe some really terrible things happened. Maybe you have some regrets that you want to forget. Or maybe you don't remember what happened. That's all binge intoxication. In somebody with the disease of addiction, that binge and intoxication flips a switch for them. They love it so much. Their brain says, oh my God, that was the best thing that ever happened to me. Better than any other great experience before. And it sends this massive dopamine surge throughout the brain. You don't have to worry about too many dopamine pathways. Just remember there's a reward pathway that ties in the amygdala, so fear and emotion response, and the hippocampus, which is memory. And those all kind of route up to the prefrontal cortex, which is executive functioning. This is what that paper goes through. So what happens is you have this binge and intoxication. Your brain sends this huge dopamine surge, and that highlights your reward pathway. And it says, oh my gosh, if I was ever afraid before, this is the cure to all of my fears and negative emotions. Your brain remembers that through the hippocampus. And the hippocampus and the amygdala are really closely located in the brain, and so they kind of like work together. So you remember emotions, and when you have certain memories, that triggers certain emotions. And when your brain knows, well, if you have a certain substance that helps numb those negative emotions, then those all kind of go hand in hand. And that also then starts affecting your executive functioning, which is your ability to make decisions. So this is why we say addiction is not a choice, because your ability to make decisions is massively reduced because of this connection through the reward pathway. That being said, I actually had a psychologist, I was talking about this to patients, and they were like, okay, cool, I got it. I had a psychologist talk to me, and she was like, well, but don't take all of the choice away from them. Because if you tell patients that they have no more choice at all anymore, then it's almost like you're taking away their hope of getting better. So you do want to be able to still empower patients when you're talking to them about having addictions, and if they've gone a certain time in recovery, do certainly educate them that there's an element of choice. They choose to get up every day and maybe go to a meeting or go to a group, maybe every other day. There is certainly an element of choice that's involved in the decision to pick up again, like there was the very first time they picked up. But it's certainly a different pathway that gets highlighted in the brain than the way that people without addictions make choices. So that's how the binge and intoxication kind of sets off the whole cascade. Then you have withdrawal and negative affect. So when you either stop using, you feel really crummy. Withdrawal from alcohol and benzodiazepines can cause seizures and death. Withdrawal from opioids is not typically associated with death and dying. We're usually pretty comfortable with people going through opioid withdrawal, except for the fact that people feel like they're dying. And they will do anything to avoid going through opioid withdrawal, which usually means getting more opioids. That negative affect can come from the withdrawal experience. It can also come from just the drugs themselves actually making people kind of feel worse. So we think of the binge intoxication as the push towards using. Like, use. It makes you feel good. It's really good. And then the withdrawal and negative affect is like the pull back towards using again. Like you pushed this way, and if you don't use, we're going to make you feel really bad. So keep going. It kind of goes hand in hand. And then finally, the preoccupation and anticipation. So this is, the brain is, I have a colleague who, she's in recovery, and she always says, whenever she woke up when she was in active opioid use disorder, she always says, I woke up every day, and the first thing that happened in my mind was who, what, where, when, why, how. Every single day, all day long, she constantly said who, what, where, when, why, how. Who am I going to call to get what I want? What am I going to get? Where am I going to get it? How am I going to get it? When am I going to use it? Constantly. Every single day. That's how her whole day was. So that preoccupation and anticipation of constantly figuring out when are you going to get the substance, how are you going to use the substance, where are you going to use the substance, and anticipating using the substance. They've done some studies and shown that the dopamine reward pathway is also triggered even when people are anticipating using the substance. So while they may be feeling withdrawal and feeling pretty crappy, once they know they're going to get it, that dopamine pathway is already fired up. This is a picture from that article that I posted by Volkow and colleagues. And this goes through those three components of the hijacked brain. Any questions on this stuff? Okay. So let's do a little patient case. Jim is a 24-year-old investment banker who binge drinks every Thursday, Friday, Saturday night, and day drinks on Sundays for football. He has missed work a few times due to hangovers and just broke up with his long-term girlfriend because she didn't like how much he drinks. He has broken his wrist and ankle on separate occasions, both when he was intoxicated. He brags about how he can drink a fifth of whiskey and still talk in complete sentences. Does he have alcohol use disorder? Yes or no? What do you guys remember from the pre-lecture? Yell it out. So yes, maybe it's mild. So I think I said, how severe is it? So what are the requirements for mild? 2 to 3. Moderate is, and then severe, 6 or more. Okay. So what are his risks, or what are his symptoms? How do you know tolerance? Because he can, yep, exactly. So we have tolerance. What else? It's affecting his work. So physical, he's using despite negative physical consequences. Yep. What else? Good question. We'll come back to amount. What else? It's affecting relationships. So now we have 4. So based on what we see here, it's moderate. There could be, like, once we actually interview him, we could find out that he has, like, a whole bunch of other terrible things that have happened, and he could have 20, who knows. But what we see is 4. I've underlined them up here. You guys want to take note. So, Rebecca, right? So, number. So, actually, if you look at the diagnostic criteria, go back to the pre-lecture slides and look at the diagnostic criteria, under none of those criteria does it say if you drink a certain amount, that equals a substance use disorder. Or if you use a certain amount, that equals a substance use disorder. Doesn't say that anywhere. Substance use disorders are defined according to criteria, mostly by what we can kind of summarize as use despite negative consequences. So ongoing use, constantly trying to keep using, craving, all of those things despite having a whole bunch of terrible things happen. And that's certainly starting to happen for this guy. But he only told us 4, so we say he is moderate. The only 2 things that are more, a little bit more objective under the criteria are tolerance and withdrawal. So if the person stops using and they go through withdrawal, that you can see that they're going through, that's an objective measure that they have physical dependence on a substance. And then tolerance, if they're able to consume a lot of that substance and still function, still kind of be normal, you can Alcohol is easy to assess tolerance because you can just use the blood alcohol content, and I don't know if I included it in the pre-lecture slides or in here, but the table that has like all of the associated values of blood alcohol content and what they're supposed to look like in a person who doesn't really have an alcohol tolerance. When you talk to people who have like very severe alcohol use disorder, they'll like walk into the emergency department with the blood alcohol content of 0.5. Yeah. Which is like dead. Most people would be dead from that. So that's how you can objectively assess tolerance. Everything else from the diagnostic criteria is asking more of these like questions about how is this negatively affecting your life. Nothing about quantity. Okay. Oliver is a 56-year-old male who presents to the emergency department saying he feels bugs all over his body and he keeps seeing scary monsters. Upon interview, the emergency department staff realized that Oliver is currently withdrawing from alcohol. Dysfunction in which of the following neurotransmitters is the cause of his chief complaint? Is it norepinephrine, dopamine, serotonin, or glutamate? Okay. So I thought this was going to happen. So let's do a little discussion. So everybody who said dopamine, why'd you say dopamine? It's a hallucination, and we know that hallucinations are associated with dopamine. If you said glutamate, why'd you say glutamate? Mm-hmm. Yep. So alcohol withdrawal primarily comes up because we have this totally like off balance reaction that happens when somebody is dependent on alcohol and has high tolerance, their body stops producing glutamate or doesn't really produce enough because you're kind of providing it this external source of the body stops producing GABA. So you're providing an external source of GABA activity to the body. The body then says, we can't handle being slowed down this much. We need to activate a bit more. And so then it has this compensatory glutamate production. Well, when you stop drinking, all of that external GABA goes away, and then you have this overcompensated glutamate activity, which is the excitatory neurotransmitter of the nervous system, is associated with seizures and a whole bunch of other bad things. So yes, while glutamate is the primary cause of alcohol withdrawal symptoms, this guy's chief complaint is a hallucination. So this is a nuanced question. I wouldn't make this a quiz. I wanted to come up with a discussion in class. But his chief complaint, because it's a hallucination, is associated with dopamine, which also was covered in the pre-lecture material, where it says if you have overactive dopamine and overactive glutamate, then you start having alcoholic hallucinosis, which is what this guy's having. Okay. Okay, so this one is another yell out what you think. Why do we see these effects? And so this is not from pre-lecture material. I want you guys to start kind of thinking out loud here. CNS problems in the couple that I have highlighted are peripheral neuropathy. Why would you think that chronic alcohol use would cause peripheral neuropathy? Related to the imbalance between GABA and glutamate? It could be that. This one's a little tricky. The way that we tend to think about it, especially with kind of like all of the chronic effects of alcohol and negative effects in the body, if you think about somebody who is constantly having a blood alcohol content of 0.5, remember that their blood is not supposed to have any alcohol in it at all. Every once in a while, college kids may binge drink and you have high blood alcohol content for like 12 hours and then it goes away. It doesn't hurt you that much. It can hurt you. But somebody who's chronically doing this, has done it for the last 10 years, has a blood alcohol content of 0.5 almost every single day. Think of that as like basically bathing your organs. Everything on the inside is being bathed in alcohol, which is not good. You don't want that happening. And it's going to start negatively affecting almost everything. With the nerves, there's a lot of like cross-interaction that happens with our nerves and like our blood and our capillaries and how they all go down to our fingertips and our toes. If the alcohol content is too high in our blood, it starts actually having damaging effects kind of all around it. And there's actually direct damage that it does to the nerves. So you get peripheral neuropathy with alcohol because that high content of alcohol in the blood is actually directly damaging nerve endings. Kind of the same way if you think about diabetes, when you have high sugar in the blood, that also directly damages nerve endings. So it's very similar. Okay. I think I just did. Oh, shoot. Okay. So we'll go to liver disease. Why do you think alcohol is associated with liver disease? Because it's metabolized by the liver. Exactly. And so when the liver starts saying, I can't do this anymore, you start getting a whole bunch of buildup of bad things. Okay. What about insomnia? Why do you think alcohol is associated with insomnia? If you remember, we talked about this. So the idea is if they're using alcohol a lot, it's constantly kind of like bringing them down. So then if they stop using, it's going to activate them and make it harder for them to sleep. That does happen. What's another one? Alcohol itself actively reduces restorative sleep too. It reduces those stages 3 and 4 sleep, and so you don't get as deep of sleep. And if you remember, what effects does it have actually? What other effect does it have on sleep? Kind of through that. Right? It decreases the stage 2, so it affects the sleep architecture. But when it comes to like the actual complaints that people will say, yes, it makes you wake up in the middle of the night and wake up earlier than you wanted to wake up. So early morning awakenings or even just throughout the night awakenings. Does all of those things. But I don't want to discount. So that definitely does happen where if somebody's withdrawing from alcohol, they also will report significant insomnia. They're withdrawing from pretty much any substance. They tend to report really terrible insomnia because their body's just been dependent on this depressant forever and everything else has been activated now. And then, I forgot. So why do we think alcohol would cause GI problems or GI bleed? Alcohol does not affect serotonin. Good idea, though. It does get absorbed through the stomach. So it can actually, because it gets absorbed, it can damage the stomach lining. And then alcohol also has an antiplatelet effect. So kind of like serotonin reuptake inhibitors can have an antiplatelet effect kind of through their action. Alcohol has a similar effect, so it's kind of like a blood thinner. And if you think about that, like if you've ever cut yourself after you've had a couple drinks, or if you've seen TV, or heard of your friends having like really terrible accidents after binge drinking, there's usually a lot of blood involved because alcohol is kind of like a blood thinner. Okay, question 5. Opioids are associated with which of the following short-term effects? Tolerance, dependence, and addiction, infectious diseases and low testosterone, hyperalgesia, sedation, respiratory depression, analgesia, sedation, and respiratory depression. So these are the short-term effects. Oh, no. Yeah, it is. Okay. Great. Why are the other answers not right? Not correct. Go ahead. Oh, go for it. Yeah. Of clotting? Not clinically. That's not something that's been seen. No. I think that even if I were to take warfarin right now, I'd have thinner blood, I'd be at increased risk of bleeding. But if I stopped it, I wouldn't be at increased risk of clotting because my body's not at increased risk of clotting. It's kind of more of the different types of disease states that people could have that might increase their risk of clotting. It's not the same as like if you think about if you were on an anti-epileptic and then you stop that anti-epileptic, you're actually at increased risk of seizures. It's different than that. Good question. For this question, why are the other answers not correct? Because they're long-term effects, exactly. Okay. All right, so let's get into alcohol withdrawal. So I'm going to teach you 3 of the most common protocols. The first 2 that are listed are the most common protocols, and then the third one is not as common, but we tend to use it a lot in the greater Boston area, and it's tending to be used a bit more widespread. And so I'm going to teach it to you because it's wonderful. Okay, so symptom-triggered detox. What this is referring to is person comes to the emergency department, they're having alcohol withdrawal symptoms, or maybe they haven't fully had a lot of alcohol withdrawal symptoms yet, but they know they're going to go into alcohol withdrawal. And the treatment team decides we're going to do this symptom-triggered detox. And what that means is they will check off a list, which I think I have a big list, but I don't need to like teach it to you all. These are the symptoms that are addressed. And they'll say like, yes, the person has nausea, vomiting, and this is how severe it is. And they'll do a scoring system. And based on that score, which identifies the symptoms and the severity of the symptoms that the person has, that'll tell the dose of the medication you're going to give them. So this is always done with benzodiazepines. I remember telling you guys that I'm anti-benzo. For alcohol withdrawal, benzos are appropriate. Just like they're appropriate to make people sleep when they're manic and bipolar. So CWA-AR is the Clinical Institute Withdrawal Assessment for Alcohol revised version. And so the CWA scale is what people talk about pretty much all the time when they're talking about alcohol withdrawal in hospitals. And it's the thing that's used to figure out the triggers the symptoms that people are having and to score those symptoms. It's not diagnostic, so it's not telling you whether or not the person has alcohol use disorder. It's just a way to measure the symptoms of alcohol withdrawal that they're having. Thing to remember with CWA is that it is reliable and validated, but only for non-medically or surgically ill patients. So somebody comes to the hospital and they're otherwise healthy, they can talk to you, and they say, I drink a half a gallon of vodka a day or something. And you're like, okay, you're going to go into alcohol withdrawal. But because you're talking to me, that means that you're otherwise okay, and we'll try to do this symptom-triggered approach. If they're drinking a half a gallon a day, you probably need a higher level. This is like the mildest level of treating alcohol withdrawal. So maybe if they're drinking a pint a day, you would go with this one. So that's the gist and the overview of symptom-triggered detox. Where does it come in? Why do we use it? So it's most appropriate, like I said, people who are able to talk to you, if they're able to communicate, because they're going to be telling you some of the symptoms that they're having. You can't tell if they're nauseous unless they're actually vomiting. So they're going to tell you whether or not they're feeling nauseous. They're not already in severe withdrawal. So they're not walking through the emergency department having already seized or showing significant signs of autonomic dysfunction and sweating profusely and all of these things. And they're not delirious. So they're in touch with reality. They're alert and oriented to person, place, and time. The 3 common medication options, like I said, always benzos, lorazepam, which, if you'll remember, is one of those LOT agents. So it's better for liver dysfunction, which we see a lot in alcohol use disorder. So we almost always use lorazepam. But also diazepam and chlordiazepoxide. The reason that sometimes people will use those 2 agents is they have much longer half-lives than lorazepam, and so you can dose them less often, and not like sometimes you can just like send people home with a couple doses to like make them be like if they're really not in severe, like very, very mild cases, you could do that. But they're kind of nice because they're a little bit easier on the symptoms of the withdrawal. So things to consider if you're thinking about doing symptom-triggered detox. So you want to take caution for all of these reasons. So really young patients, people who have a history of sedative, I shouldn't have the word abuse here because I don't like that word, but people have a history of overusing or misusing sedative hypnotics. Sedative hypnotics are benzos, Z drugs, other things that slow down the CNS. The reason that you want to take caution is because maybe they're going through alcohol withdrawal, but if they're also dependent on benzos maybe, then their tolerance is actually way higher. So it's kind of like somebody who, they'll go through a more severe withdrawal because they have really high tolerance than somebody with lower tolerance. People are using clonidine or beta blockers because that's going to be affecting their autonomic function. People at risk for paradoxical disinhibition with benzos. So we tend to see this more in people who might have a acute or chronic traumatic brain injury, people with neurodegenerative disorders, or people with a history of alcohol-related blackouts and or assaultive behavior. You really want to avoid it, but maybe it's not totally contraindicated in patients, but it's like really not recommended. Patients with a history of severe alcohol withdrawal. And what that looks like is delirium tremens, alcohol withdrawal seizures, if they didn't respond to benzos. So they were being given benzos, and they were still having symptoms on top of that. People with a history of an ICU admission for alcohol detox, current signs or symptoms of delirium or encephalopathy, or people that have already or are at risk for respiratory compromise. And the reason you'd want to avoid benzos in that population is because benzos slow down the respiratory drive. And so you could end up having to ventilate them. All of these other reasons are all signs and symptoms of very severe alcohol withdrawal, which means you're going to need another step up. You can't just kind of like wait for them to tell you that they're feeling bad. Total contraindications for symptom-triggered detox are people actively having delirium tremens or severe withdrawal that are not responding to benzos, or people with altered mental status or that have delirium. So the way that this, so the next category then is standing benzo-based detox. So the first one was symptom-triggered, and sometimes you can get away with only giving people like 4 to 6 milligrams of lorazepam on the first day, a little bit less the next day, and then they're good on day 3. You just send them home. Standing benzo-based detox usually means longer hospital stays because they require a lot more care. And this is typically for people in more severe or at risk for more severe alcohol withdrawal. You don't need to remember any doses of this stuff because it just depends. But so standing benzo-based detox is best for people for whom CWA is contraindicated. And CWA is symptom triggered, so this is the things to think about. If they have a CWA score over 16, because that means that they're already in decently severe withdrawal, and if they have history of severe withdrawal. So DTs, alcohol withdrawal seizures, not responding to benzos, or an ICU admission associated with alcohol detox. Like I said, this is just an example, so it's like a standing decent dose of one of the benzos, like 2 milligrams every 4 hours, but then you also get as-needed doses every 1 hour if you're having breakthrough symptoms. So things to consider with standing benzo-based detox. You want to take caution in patients who are on a whole bunch of other meds, especially if those other meds are CNS depressants, like opioids, which also reduce the respiratory drive, and so you could actually be increasing that person's risk for overdose and death. People actively having delirium tremens or with severe withdrawal symptoms not responding to benzos. So maybe you put them on the standing benzo-based detox and they're still having a ton of symptoms. Even as you add in the PRN doses of lorazepam, they're still having active withdrawal symptoms. People having altered mental status or those at high risk for delirium, or people at risk for the paradoxical disinhibition, which were the same reasons that we talked about in that previous slide. And then you want to avoid standing benzo-based detox in people who currently have or are at risk for respiratory compromise. So then it's like, okay, well, what do we have next? So I've worked in hospitals where it was CWA or standing benzos, and that's it. I did not hear about phenobarbital until I came to Boston. And we just kind of like had to deal with it. We basically, we would like load them up on benzos, and then if they started going to respiratory failure, we'd ventilate them, keep them on benzos until they detox, and like just taper the benzos, and then eventually like remove the ventilator. And that was how it was addressed. But now there's this wonderful thing called phenobarb, which has been around for like 40 years or 50 years. So the cool thing about phenobarbital is that it activates GABA, but then it also decreases glutamate, whereas benzos just activate GABA. So what we're doing with alcohol detox, with benzos, so remember the glutamate's up here and the GABA's like way down here. So we're bringing the GABA back up, and then we're slowly reducing the GABA by like slowly tapering the benzos, waiting for the glutamate to come down, and then you reduce again, and then you wait for the glutamate to come down, and so on and so forth until you're off of them completely. Well, with phenobarb, you kind of get to do both of those things pretty quickly. So we don't end up seeing very much change in mental status with phenobarb, and we don't also see that paradoxical disinhibition. So the people that are at risk for having that, and what disinhibition means is like normal people who take benzos get sleepy and they just kind of like pass out, and that's what they're doing for the day because they took a benzo. Paradoxical disinhibition is they take a benzo and it like puts them into a delirious state and they get like awake and agitated and all of those things. So the cool thing about phenobarb is that the pharmacokinetics are reliable, so we can do therapeutic drug monitoring and target certain serum drug levels. It's long-acting, so it auto-tapers. So if somebody leaves the hospital against medical advice, the medication's going to auto-taper, and the person can just, like, it's safe for them to just kind of, like, be out on the streets. It stays in their body for, like, a week and a half. And it has a relatively wide therapeutic index, so it's relatively safe even if we do kind of give them too much. When do we use phenobarb? Anybody who has a very high risk for having severe withdrawal symptoms. So active DTs, seizures, history of benzo non-response, history of prior ICU admission, currently showing signs of delirium or encephalopathy, or if they're at risk for the paradoxical disinhibition like we talked about, or if they're at risk for respiratory compromise because phenobarb doesn't slow down the respiratory drive as much as benzos do. It does it a little bit, but not as much. So things to consider with phenobarb. I have this here because this is the protocol that we use at MGH. You don't need to memorize it. I put here levels are FYI, so you don't need to care about like, well, if they're at low risk for respiratory compromise, then we should be targeting 12 to 15. Don't worry about that. Just think about the like take caution and the contraindicated things, and do that for each of the different pathways. So, withstanding phenobarb-based detox, you want to take caution in people who have a history of cirrhosis, which is tricky because a lot of people with alcohol use disorder have a history of cirrhosis. It doesn't mean we can't use it though. You just take caution and use a lower serum target level. You can also limit the maintenance taper to 2 days to allow for the auto taper. So because it lasts so long in the body, in somebody with cirrhosis, it's going to last even longer. And so typically we'll do phenobarb for, the ideal course is 7 days. But in the first 3 are like the required days that the person has to stay in the hospital. In somebody who has liver or like serious hepatic impairment, we'll only do 2 days after the first 3. If they stay around. But ideally, we would do 4 days after the first 3 if they don't have cirrhosis. It's contraindicated in people with acute intermittent porphyria, with history of SJS or toxic epidermal necrolysis, because it can cause severe rash, deadly rash, or people who have a history of rash to any other anti-epileptic drugs, because they might be at bigger risk of having a rash to phenobarb. Okay, so another question on alcohol withdrawal. Which neurotransmitter is associated with the development of all types of complicated alcohol withdrawal? That means delirium tremens, alcohol withdrawal seizures, and alcohol hallucinosis. GABA, serotonin, dopamine, or glutamate? Okay. So this is tricky because of the other question that I had. What I was getting after with this question, so GABA is associated, right? Why is GABA associated? Because it's the main effect of alcohol. So we know that GABA is like related. And then we know that glutamate's associated because we just talked about that. GABA goes up, glutamate goes up, you take away GABA, and you have glutamate high. So while dopamine is important for delirium or the hallucinations, it's not necessarily needed for something like an alcohol withdrawal seizure. So what I was going after for this one was just glutamate, because it's like kind of the culprit that starts everything getting really bad. It's like the first step is seizures, the second step is you add dopamine and you get delirium, and the third step is you get delirium tremens when you add norepinephrine. And if you go back through in the pre-lecture and kind of follow through that animation again, like the more you watch it, the more you'll be like, okay, this makes sense. If you have any questions, don't hesitate to post on Blackboard. Okay, another patient case. Jimmy's a 39-year-old male with severe alcohol use disorder presenting to the emergency department for detox. He reports feeling jittery, has a headache, nausea, increased blood pressure, and increased heart rate. He is alert and oriented ×3. How should his alcohol withdrawal syndrome be treated? Send him home, he'll be fine. Symptom-triggered detox using CWA, standing benzo-based detox, or standing phenobarb-based detox. Okay. All right, cool. So why do we think symptom triggered? Yeah, what helps us say that it's maybe kind of mild? Exactly. And he's talking to you. He's able to articulate what's going on. Yeah. The reason, and I didn't highlight this in the lecture, but the reason that you always want to go for like the least intense version of a detox protocol, which usually is CWA if you can, because it reduces hospital stay and it reduces a ton of complications. The more benzos you give to people, the more likely they're going to have a whole bunch of other problems. Standing benzo-based detox is associated with significantly longer hospital stays because people are more likely to require intubation because they're more likely to have respiratory depression, which also could be like, significantly increase their risk for like ventilator-associated pneumonia and all of those things. So the least intense version of a detox protocol is the one that's preferred, if possible. And so try to think of what's the kind of patient that we're looking at, and what's the least intense version of a detox protocol that we can go for to match with that patient. You were going to ask a question. Yeah, so I think I sort of put, oh no I didn't. So you don't need to know okay. So what happens is there's you'll have like a paper sheet or an electronic medical record chart that says all of the different symptoms on it. And then if the person has them, you like rate them between mild and severe. And those ratings between mild and severe will give the person a certain score. So it'll be like, and it's somewhere between 1 and 7. But some of the little symptoms are like, you can't rate them a 5. It's like 1, 4, or 7. If it's an electronic medical record, it'll total up the symptom scores for you. And so if it's something like a CWA score of 10, that'll tell you to give a certain dose of a benzodiazepine. And you do that like somewhere between every 2 and 4 hours. Typically, nurses don't like doing that much stuff, so they'll go every 4 hours to do CWA. And that's the symptom-triggered detox. So it's not that there's a defined dose, and like every hospital is different. That's why I don't care if you guys memorize doses for this stuff. It's just that there's the 3 most common drugs, which are lorazepam, diazepam, and chlordiazepoxide. And then it's just knowing that based on a certain score that you get every couple hours, that'll tell whether or not a nurse should give you an additional dose of a benzodiazepine. Does that help? Nope. So good question. Okay. So with symptom-triggered detox, it is PRN. Like it's basically only as needed. So what happens is a nurse goes in, does the assessment every couple hours, and if the person doesn't have any symptoms, they're not going to get a dose. Or if they only have mild symptoms, they're not going to get a dose. So it's only as needed based on whether or not the symptoms trigger a dose. That's why it's called symptom-triggered detox. Yes, right, exactly. So think of symptom-triggered basically as like PRN, basically, and then standing is standing. So it's a scheduled medication that they're getting every 4 hours usually, plus as needed on top of it. It depends on how severe the person's withdrawal is. So a lot of times people can do symptom-triggered detox in a couple days, like 2 days, and they're out. But like I said, the more intense that their alcohol withdrawal is, the more likely that they're going to have complications, and their hospital stay can take a really long time. That part depends. So phenobarb, they have to be hospitalized as well. So alcohol withdrawal is another case of you probably require hospitalization no matter what. I've heard of some psychiatrists will they'll like, if somebody says I want to cut down on my alcohol, I think I'm going to have withdrawal symptoms, and maybe they'll prescribe an outpatient benzo for a little while. It's not the safest option. Alcohol withdrawal, because you can die from it, it's something that we do want to treat in the hospital. So all 3 options are all treated in the hospital. Most of the time, it's somebody presents to the emergency department for some reason or another, and they start going through alcohol withdrawal, and then they decide what option they're going to do. Phenobarb, what I was trying to say was that they could go home after only the first 3 days, even though they haven't completed the whole protocol, because it lasts so long in the body. So they're not like getting a prescription and going home with that. It's just that the drug itself is still in their body for like 7 to 10 days. Okay, any other questions on these 3 topics, options? Okay. Another case. Diana is a 60-year-old female with severe alcohol use disorder and long history of frequent ED presentations for alcohol detox. She has witnessed seizures, so she has had witnessed seizures in the past, twice requiring admission to an ICU. How should her alcohol withdrawal syndrome be treated? Send her home, she'll be fine. Symptom-triggered detox, standing benzo-based detox, or standing phenobarb-based detox. Okay, and this is actually not, I'm okay with this response because it's neither C nor D are wrong. I would recommend D because the person's had a history of very severe withdrawal. And so like if somebody were to come up to me in the hospital and say, do I do phenobarb or standing benzo? I would say do phenobarb. But it's not totally wrong to do benzo, especially if you're in a hospital that doesn't do phenobarb. Benzo is your only option. So this makes sense. If you had all 3 options available to you, though, and you really wanted to make sure that this person was going to have a smooth alcohol withdrawal treatment, you would try to do phenobarb. Oh, go for it. Mm-hmm. Yeah, so try to think of phenobarb and standing benzo-based detox as both kind of intense. Those are both like for people that are at risk of having severe alcohol withdrawal. And then symptom-triggered is the least intense one. So those 2 are standing benzo-based detox and phenobarb-based detox are both kind of the same. It's just that phenobarb has like a lot fewer risks of like adverse effects. So we kind of like that one a bit more. And when the benzos don't work for some reason or another, so like another way I could have written this question is like, also has a history of benzo non-response. Then like it makes perfect sense to do phenobarb because we know that the benzos aren't going to work. Does that help? Okay. If you're in a hospital that doesn't have phenobarb, or like doesn't have a phenobarb protocol, and that's pretty much it, I'll be honest. I would make it more obvious. Mm-hmm. Sometimes I just do this because I like the discussion in here. Okay, so on to alcohol use disorder. So somebody comes in for alcohol withdrawal, they get admitted, they get treated. Do we just kick them to the curb and say, okay, we'll see you next week when you come back for alcohol withdrawal? No. Detox is not treatment. Remember that. Just detoxing somebody and sending them home is not treating them. You have to treat them. So, what does treatment mean? Well, now we're getting into addiction treatment. So, alcohol use disorder, what we first want to do is the detox part, so prevent or treat withdrawal symptoms. Ideally, with alcohol use, we want to stop people from drinking alcohol if they have alcohol use disorder. We haven't found another way of being able to do some kind of like maintenance treatment or maintenance therapy. Sometimes you guys may think like, well, what if you did like low-dose benzos forever, you know, and it just kind of like maintained their tolerance, maintained their whatever GABA activity, but they didn't like, as long as they're not drinking alcohol, maybe this is better. It just never turns out that way. Once they have alcohol use disorder, if you give them benzos, they love benzos. And in fact, sometimes benzos are easier because it's like less volume, and it's doing the exact same thing to them. So the other thing, though, you can consider is more of like what we call harm reduction approach, which is reducing the amount that they're drinking. In people with milder alcohol use disorder who just say like, you know, come in your office, they say, Doc, I want to cut down. You know, my wife's a little annoyed that I drink during the football games and like, you know, have drinks every other night of the week. What do I do? Well, you can still help them cut down and reduce their drinking without telling them that they have to stop drinking completely. And then, so you want to achieve that abstinence or reduction, and then you want to maintain that abstinence or reduction with continued treatment. Because you can't just like have somebody be like, okay, cool, you stopped drinking. Like, you're done now. That's great. You know, see you for your annual physical next year. Like that, it doesn't work. In order for people to actually be treated with substance use disorders, they need constant engagement in treatment. So there are non-pharmacologic options. There is psychosocial treatment, and it's important to have a good understanding of the fact that psychosocial treatment is kind of a cornerstone of addiction treatment. Without psychosocial treatment, pharmacotherapy doesn't really do that much. Pharmacotherapy is like maybe a Band-Aid, or it might be like literally nothing at all. Especially with alcohol use disorder, you really have to combine the two. About 2/3 of people involved in psychosocial treatment, so in a study that was done, published in New England Journal in 2013, 2/3 of people who were involved in psychosocial treatment, and so that's therapy. That's basically like some sort of therapy. There's a lot of different types of therapy and a lot of like supportive type therapies that go in to helping people with substance use disorders. But so, of the people that engaged in that, 2/3 were abstinent at 3 years versus only 43% who didn't engage in treatment at all. So significantly over half versus significantly under half. So we know that psychosocial treatment definitely works and it helps people. Unfortunately, only about 25% of people with alcohol use disorder ever actually engage in that treatment. There's a whole bunch of treatment options. You guys don't really need to know them, but this is just to show you that there's a wide variety. But the other thing we can do is we can combine pharmacotherapy with it. We know that what studies have shown is that if we combine pharmacotherapy with the psychosocial therapy, then we get better results. So we have 4 FDA-approved agents. I'm only going to test you on the 4 FDA-approved agents. I don't have the non-FDA-approved agents, but we do use a bunch of other things too, which you'll see if you come on my rotation. But first we'll start with disulfiram. The brand name of that is called Antabuse. So the way that disulfiram works is the way that alcohol metabolism works. Person drinks alcohol, alcohol dehydrogenase breaks it down to acetaldehyde. Acetaldehyde dehydrogenase then breaks it down to acetate. And then that's how the liver, and like all this happens in the liver. So disulfiram blocks acetaldehyde dehydrogenase, and it causes, if somebody drinks alcohol, it causes a massive increase in acetaldehyde. And what happens is then facial flushing, sweating, headache, nausea, vomiting, and tachycardia, and a whole bunch of other symptoms that we'll talk about in a minute. So basically it's like punishment for drinking. So if you're taking this medication and you drink alcohol, you get a really bad reaction. So dosing is outlined up here. Important to note that the patient has to wait at least 12 hours before taking their first dose after drinking. And that's because of that reaction that we don't want to have happen. For monitoring, you want to make sure, so we want to do efficacy monitoring, so reduction in alcohol consumption, reported cravings. and non-pharmacologic treatment adherence, so whether or not they're actually going to therapy. And then for safety, any sort of facial flushing, which can happen even without having alcohol, and then increased LFTs can happen with disulfiram. There's a bunch of adverse effects. Some that are a little bit worrisome are things like psychosis. A lot of people do report that weird aftertaste. And hepatitis, which is not good considering alcohol use is also associated with liver impairment. Significant drug interactions. Disulfiram has a metabolite that inhibits 3A4. If you combine metronidazole with disulfiram, then you can also get, so this is confusing. If you combine alcohol with disulfiram, you get this disulfiram reaction. And you've maybe heard of it before if you guys had infectious diseases and they talked about metronidazole. And if you have metronidazole with alcohol, you can also get a disulfiram reaction, which is the one that we talked about, the flushing, the nausea, vomiting, all of those terrible things. If you combine, I won't test you on this because I don't have it on the slide, but if you combine metronidazole with disulfiram, you can get worsened psychosis somehow. They don't have a mechanism of action for that, but it can make people like really dangerously psychotic and like require hospitalization and all of that. So counseling points, it can take up to 14 days for liver enzymes to return to baseline after stopping disulfiram. So if somebody does have increased LFTs, it'll take a while before we can see them, we'll see them reduce. And then, oh yeah, here. So avoid metronidazole because of that psychosis thing. And then, of course, any alcohol-containing products. So when I say any alcohol-containing products, I mean like cough syrup you can't have, mouthwash, even just slushing it around in your mouth can cause a reaction. Using hand sanitizer can actually cause a reaction because your skin sort of absorbs some of that alcohol that's in hand sanitizer, and it's really bad. And then thinking about, so duration of therapy is intended to be indefinite, remembering that patients have alcohol use disorder forever, and if you're constantly trying to deter them from using alcohol with disulfiram, you just keep taking it forever. So what is the disulfiram reaction? It's all of these things. It's really uncomfortable. People feel really awful. It's really, really terrible. And most of the time it's not dangerous, but it can actually be really dangerous and cause things like at the bottom half of the screen, where you see respiratory depression, cardiovascular collapse, arrhythmias, heart attacks, acute congestive heart failure, unconsciousness, seizures, and death. So, do we think that we use disulfiram a lot based on that? No. The risk of somebody picking up another drink again is not low. Like, they're probably going to drink again. Just always kind of having that in the back of your mind. So, if you start them on a medication that could kill them if they drink again, it's not a good idea. You might get sued. We, even totally aside from that, what we do tend to find is that people just don't take it. They'll maybe start taking it for a couple days, then they'll stop taking it, wait a couple days, and then start drinking again. It can be effective, though, and I have seen it used pretty successfully in people who are like really motivated. They come in, they go through withdrawal, they tell you in the hospital, like, I want antabuse. I know that like this is what's going to work for me. Maybe it's worked for them before. And they say, like, I never want to drink again. I need that punishment. That's what motivates me. There's also, in certain states, certain Department of Mental Health agencies and stuff can mandate that patients take disulfiram, which is really kind of unfortunate. But if they mandate that the person takes disulfiram, they basically like go to like a health center basically every single day and get dosed, kind of similarly to somebody getting dosed with methadone for opioid use disorder. The other reason that we don't use disulfiram very much is that the data shows it doesn't work. It's not different than placebo. So, and I think that the big reason for that is because people just stop taking it. We know that in order to motivate people, punishment doesn't work in like basically any setting whatsoever, and the same holds true for trying to get them to stop using a certain substance. So question 9, this is going to be like a yell it out answer. Hank is a 45-year-old male who has struggled with severe AUD since he was 20. He has been in and out of detox programs but struggles to continue with treatment thereafter. He asks you for a medication that will make him not want to drink, one that would make him ill if he did drink. Would you recommend disulfiram? You would. Maybe. I said probably not. So I would say I'd want to make sure he really hasn't tried anything else. I'd want to make sure that he would have the ability to take the dose every day. So sometimes what people do when they're really motivated to take disulfiram, if they have like a spouse who lives with them, that spouse will be the person who doses them every single day, and they'll monitor that dosing every single day. Without that other external support, it's really not a good idea to do disulfiram. He has a high relapse risk. That whole he's been in and out of detox programs, struggles to maintain treatment, makes us really worried about a disulfiram reaction that could hurt him. So that's that. So next we'll talk about naltrexone, which is in two forms. There's oral and intramuscular. So the way naltrexone works, alcohol, when we drink it, it increases our body's endorphins. Endorphins are our body's natural opioids. So endorphins will bind to opioid receptors, and they activate them. So if you get hurt when you're drunk, you actually don't feel the pain as much, and that's because of this stuff going on. Because it activates opioid receptors, that activates our dopamine reward pathway. And so we have massive reward that happens when we drink alcohol, and then that says, give me more alcohol. And then you just start this cycle over and over again. So the way naltrexone works is it blocks the way that it blocks endorphins from binding opioid receptors. It completely blocks opioid receptors so that nothing can bind to them. So then you stop this reward from happening when people drink alcohol, and that says, maybe I don't really want another drink after this first one. So like I said, there's an oral version that's 50 milligrams once a day, and there's an extended release intramuscular injection called Vivitrol, which is 380 milligrams intramuscularly in the gluteal muscle every 4 weeks. Monitoring parameters to monitor for efficacy, you want to monitor alcohol consumption, craving, and then non-pharm treatment adherence, so engagement in therapy. And then for safety, you'll have to monitor for any LFT abnormalities because it does affect the liver a little bit. Nausea, anxiety, and dizziness are commonly reported adverse effects, especially in the beginning. Other adverse effects are listed here. Another big one is opioid withdrawal. If the person's dependent on opioids and we block their opioid receptors, what do you think is going to happen? Massive opioid withdrawal. It's called precipitating opioid withdrawal. So they have opioids kind of on all of their opioid receptors all throughout their system, and then you give them an antagonist that kicks off all of the opioids from all of their opioid receptors, and you throw them into opioid withdrawal, which if you remember, even though opioid withdrawal can't kill you, it feels like it's killing you. So it's really terrible. And then another really common one is injection site reactions, which you don't need to get into the details, but it is pretty common. So drug interactions, like I just said, opioids. It has no other drug interactions other than opioids. And what that means is if somebody's even not dependent on opioids and they're on naltrexone, they get into a car accident, and they need opioids for pain management, opioids aren't going to work. And that scares a lot of people. The way we talk through it is saying, what's your risk of picking up a drink again without this medication? We know it's like 70%, maybe even higher. It's like 90%. What's your risk of getting into a car accident or getting hit by a car or whatever, needing, really severe pain management? It's like, what, 1%, maybe 0.1%? And so you kind of try to use that to help the patient kind of reason out, well, okay, what are the risks? What are the benefits of this medication? Some people will say, no, like, I'm afraid of getting hurt. I don't want to deal with that. And that's fine. Duration of therapy for naltrexone is also indefinite. We tend to say with any pharmacotherapy for addiction, kind of like with all of the other, depression and anxiety, try to go for at least a year. Go for at least a year. Start changing your habits and behaviors. After 12 months, a lot of your behaviors should probably have changed. You've probably gotten used to doing things differently as you're not using this substance anymore. And so after that time, you can go to your doctor, say, I don't want the next dose. And then talk about what other supports are you engaged in, what else do you have going on that's going to prevent you from relapsing. For counseling points, make sure that the patient has not had opioids in the past 7 to 10 days. We will drug test patients to make sure that they have no opioids in their system, at least on the drug test. You want to review any potential adverse effects and ensure the patient understands that traditional pain meds won't work in an emergency. So other things to consider for naltrexone, As for its role in treatment, it's very good at maintaining abstinence. So we'll still start it in the hospital, especially if somebody in the hospital has been there for maybe like a week for some reason or another. Maybe they're being treated for a bunch of other things. We'll get started on the naltrexone, and then it's good at kind of maintaining their abstinence. It's less good at maintaining abstinence if somebody is like currently actively drinking and you just give them an outpatient prescription and say maybe this is going to help. It's not as good in those situations. It's effective for reducing the quantity consumed, though. So we tend to really like naltrexone for patients who have a history of binge drinking episodes because it can actually, the data shows that it does reduce the quantity of drinks drank in a certain time period. There is a REMS program for the Vivitrol or IM formulation, and that's related to the injection site reactions, and so there's just some extra education. You don't need to be registered with the REMS program. It's not the same as like Accutane or clozapine. It's nothing like that. It's just some extra safety measures just to make sure that people are all educated on what to do for naltrexone. The IM injection is, of course, useful for people if you're concerned about them being able to take a medication every day. It also helps them at least make sure that they have to be engaged in treatment. They have to go to the clinic at least once a month. Make sure that when the other thing when you're counseling patients is to encourage that they wear medical alert jewelry or have a wallet card. If they have Vivitrol, the cool thing is that because it's on label, the drug company makes little bracelets and little dog tag necklaces for you to hand out to patients. And so we do that all the time. And then, of course, like I said on the previous slide, you have to ensure that the person has not had opioids in the last 7 to 10 days. That's the biggest thing to remember with naltrexone. No opioids. Okay, on to acamprosate. So mechanism of action for acamprosate is not fully defined, but it looks structurally similar from like the molecule standpoint of similar to GABA. It seems to increase GABA activity and reduce glutamate activity, kind of like what we remember from phenobarb, but to a much lesser extent. And then somehow, because of these actions, restores the balance between GABA and glutamate. However, despite doing these things that it maybe allegedly does, this is literally like how their scientific papers are written, that it's like maybe doing these things. It does not cause any anxiolysis or have any anticonvulsant effect. Oops. So the dose for acamprosate is 666 milligrams, which only come in 333 milligram tablets. So they have to take 2 tablets, and they're kind of big, and they have to take them 3 times a day. So that sucks for adherence. You want a dose adjust if somebody has renal impairment. So if their creatinine clearance is between 30 and 50, you would go down to just the 333 3 times a day. And then it's basically, it's not contraindicated, but it's you're told to avoid it if the person has renal impairment with creatinine clearance below 30 milliliters per minute. You'll also want to dose adjust if they are relatively lean with a body weight less than 60 kilograms. You would also do the half dose, or if they have history of response to a lower dose, which would be kind of hard to determine. For the most part, we just start everybody at 666 3 times a day and tell them to go on their way. The efficacy parameters are the same as they were for naltrexone, and then for safety, you'll be monitoring renal function because acamprosate is cleared renally. Also monitored for signs of depression and suicidal thoughts because there were a couple of post-marketing reports that associated with acamprosate with depression and suicidal thoughts. Diarrhea tends to be the most common adverse effect, happens in like 1 in 10 to 1 in 5 people. But then a little bit of maybe nausea, and then we do see, or because of those post-marketing reports, we tell people to look out for depression or increased anxiety. There are no drug interactions. It's cleared completely renally. And again, duration of therapy is the same as for all the others. It's not defined how long they should be on it, but it should be at least a year. Counseling points, we just do review adherence strategies. So when you're talking to somebody who needs to get used to taking 2 tablets of something 3 times a day, I mean, a lot of the patients that we treat don't take any medications because they're just drinking all day and they don't care about their health. So it's a big ask to tell them, like, now you're going to take this medication 3 times a day. So just really reviewing all those adherence strategies with them. And then also, because acamprosate's working on the neurotransmitters in the brain, it's kind of, you can think of it kind of like how antidepressants work, where you're going to be adjusting like the receptor activity and all of that stuff. And so it does take somewhere between 4 and 6 weeks before people might actually notice a difference in their cravings. That being said, I've had patients say, like, as soon as they take it, they notice a difference. I've had other patients say they've never noticed a difference. So everybody's different. So acamprosate is also better at maintaining abstinence rather than just starting it in the middle of somebody actively drinking. Here I have 4 to 8 weeks until efficacy onset. Just know that it's several weeks. Theoretically, because acamprosate and naltrexone both work totally differently, if you were to combine them, then you'd be combining 2 different mechanisms of action, and maybe you could get more effect or better effect. However, the data for that is totally conflicting. Some of the studies are positive, and then there was a huge study that was negative. So we don't tend to use it very often, but I have seen it done. With acamprosate, there is a high likelihood of non-adherence. So typically, we tend to think of our first choice is naltrexone. If somebody has alcohol use disorder and they're willing to start a pharmacotherapy, we first want to try naltrexone. But if they have severe liver impairment, or they're on opioids, or they might be on opioids for some reason or like in the future, or they're really afraid of the whole opioid risk if they get into an emergency situation, then we go to acamprosate. So acamprosate, we do use it. Definitely use it pretty often, especially because of the whole severe liver impairment with naltrexone thing. But we don't prefer it first. So we have another patient case, and then we'll take a break. CT is a 49-year-old female with a 25-year history of alcohol use disorder. Her past medical history includes depression, generalized anxiety disorder, migraines, partial seizures, and she status post spinal fusion in 2011. Her father had alcohol use disorder. He developed Alzheimer's disease and died at age 75, and her mother died of lung cancer at age 67. She, as we know, drinks alcohol. She began drinking at age 15. She denies illicit drugs. I think the 15 and the 25-year history don't add up, but ignore that. She worked as an ICU nurse until she needed the back surgery in 2011. For meds, she's on Effexor, which is what? Venlafaxine. Keppra, do you guys know that one? Levetiracetam, okay. And clonazepam for anxiety. She has a penicillin allergy. You can see her vitals, which are all pretty normal, and her creatinine clearance is normal. So how many risk factors for alcohol use disorder does CT have? 1, 2, 3, or 4, and that goes with A, B, C, or D. Or I think that's what it is. Sorry, other way. 4, 3, 2, or 1 goes with A, B, C, or D. Okay. Oh boy. So I hate when I lose that little screen. So she had 3. You guys know what the 3 were? What was that? Family history. What was that? Young age, family history. And comorbid psychiatric illness. Exactly. So whenever you guys are going through these things, just like underline, you know, what you know. Like remember the risk factors and start underlining. Like, okay, what are these things? And then just count them. It's pretty straightforward. All right, what severity level would you use to classify her AUD? And I've already denoted which symptom she has. And it's just A, B, or C. Okay. So most of you said severe, a couple said mild and moderate. So let's just review. What's the criteria for mild? Meeting 2 to 3. Moderate is 4 to 5, and severe is 6 or more. And so she has 1, 2, 3, 4, 5, 6, 7, 8. So she has severe. Okay. CT's provider has not had much experience with treating alcohol use disorder, which is very common. So he asks a clinical pharmacist for a recommendation on starting pharmacotherapy. Which of the following is the most appropriate choice? Disulfiram, naltrexone, acamprosate, or the other version of naltrexone? Right, so most of you guys said naltrexone orally, 50 milligrams daily. There was a cohort that said naltrexone intramuscular, but notice that this says once weekly and it's a once monthly injection. So remembering to pay attention to regimen as well. We hardly, like I said, we hardly ever use disulfiram unless somebody is like totally committed and we know that they have a lot of supports in order to help them make sure that they're taking it. And then why not the acamprosate 333 by mouth 3 times a day? You guys are whispering. Yes. It's not the right dose. The right dose is 666 3 times a day. If she had impaired renal function, then that would be the right dose, and it would be a reasonable thing to consider, but it's not the right dose. Okay. So let's 5-minute break. I will start at 9:55 because I want to make sure I get through everything. Then we'll jump into opioid use disorder. Delirium tremens is DTs. Opioid use disorder. So I talked a lot about opioid use disorder in the pre-lecture, like a lot of the background stuff. And so this is getting really just into what do we do for people who have opioid use disorder. So there are several clinical interventions that we can do. Another, I don't have it, I didn't highlight it on this slide, but we also want to make sure that we're engaging people in psychosocial treatment as well for opioid use disorder. For all addictions, we want to make sure that we're engaging people in psychosocial treatment. But then thinking about, well, what can we do medication-wise? So there's what's called kind of maintenance treatment, which is buprenorphine products, methadone, and naltrexone, and we'll talk about how those all kind of play a role for opioid use disorder. And think of maintenance treatment the same way you think of insulin as maintenance treatment for somebody with diabetes. And then there's what to do in the case of an opioid overdose, and that's when you use naloxone or Narcan. If you'll remember, like I said, detoxification is not treatment. So if somebody comes in and says, I need detox, and they go to a detox facility and they detox for 5 days, and then they come out, we call that spin dry. Like they basically have just like done their spin dry and then they're out, and then they pretty much will pick up using again if they don't have the supports built around them. So, methadone. These little images are just to kind of show you, imagine this is a mu opioid receptor, and methadone fits right, like nicely into that mu opioid receptor. It's a perfect lock and key. Methadone is a full-acting mu opioid agonist. It's long-acting, so it stays in the body for a really long time. And then these are basically a whole bunch of clinical pearls to think about with methadone. So the way that it works is it's an opioid. So you're replacing something like heroin with something like methadone. It's a fully acting opioid. The difference is that because it's so long-acting, we can mess with the dose in a way that we prevent you from feeling high, so prevent you from getting that huge dopamine surge that you would get when you use a whole bunch of heroin. And then we also will maintain your tolerance so that if you do use again, you won't overdose, because overdose depends on how tolerant you are of a certain amount of opioids. And then we also prevent you from having cravings to use again. So it's kind of that threefold approach that these medications are taking, that something like methadone is taking. So it maintains your tolerance to prevent overdose. It prevents cravings. And the other thing that it can do is it can actually block the effects of other opioids if you get to a high enough dose. That dose cutoff is 60 milligrams a day. So if you get to 60 milligrams a day of methadone, The effects of other opioids, like if you were to use heroin on top of it, you wouldn't get that additive effect of heroin because methadone binds strongly enough to the receptors and you have enough of it in your body to block the effects of the other opioids. In order to get methadone, you have to be registered in a registered clinic. So clinics are registered like with the DEA and all of that stuff. They're highly regulated. And the patient has to be enrolled in this clinic. Like, you can't just show up and be like, give me my methadone for the day for the first time. There's usually considerable, like there's an intake process where somebody has like a big long interview and then agrees to do some sort of programming at the clinic in order to kind of get them on the path towards recovery. We tend to think of methadone, it's not always thought of this way, but we kind of think about it as best for people who've been using for a lot of years, who have very severe opioid use disorder. Especially because of that, using it for a lot of years with very severe opioid use disorder, they probably have a very high tolerance. And what's nice about methadone is we can keep increasing the dose and we'll keep getting more and more effect. So we can titrate the dose to their tolerance in order to block their cravings while not getting any sort of euphoria or high from that medication. If the person has chronic pain, methadone, I have here better for patients with comorbid acute or chronic pain. It can be better, it can be not so great. But if somebody has, like if somebody's in the hospital and you're going to start them on an opioid use disorder treatment and they have a broken leg, that's fine to start with methadone because it's going to help with their pain and you're also treating their opioid use disorder. The reason it's not great for chronic pain is because it has to be, its effects, which I have this I think on the next slide, but its euphoric and analgesic effects only last about 6 to 8 hours. However, that preventing craving and preventing withdrawal, all of that stuff, lasts over 24 hours. So we only need to give it once a day in the morning. However, if you give it that once a day, and then after 8 hours, the person's still in pain, or the person's pain comes back, they're not going to get their next dose until the next day. So they could be dealing with a lot of pain for another 16 hours of that day. Methadone does have a lot of drug-drug interactions, and so you definitely want to monitor and see anything newly that's added on, make sure that you check it against methadone drug interactions. You have to monitor the QT interval. You have to get baseline EKG to make sure that the QT interval is normal, which basically, if it's like less than 480, that's fine. And then you would get another EKG 2 days after starting methadone. And if the EKG or the QT interval goes up to more than 500 milliseconds, you have to really consider the safety of continuing methadone because it could progress into torsades. It's pretty common to see very high doses of methadone. It's not usually a good sign. Sometimes people will be kind of yanking the chain of the clinic and trying to get higher and higher doses because they will get high from it. They will feel an effect. But it's not great. So, I mean, we've had patients come in and on like 150, 160, 170 milligrams a day. And it's very rare that somebody actually needs that much methadone in order to cover their cravings without getting them high. But it's just to let you know that it's pretty common to see those high doses. So other things to think about with methadone, it is considered a first-line treatment for opioid use disorder. Like we talked about, analgesia and euphoria last only about 6 to 8 hours. So the tricky thing is, if somebody gets sent home with a prescription for methadone, because you can actually prescribe methadone for pain in an outpatient setting, and it's totally fine. If that person has opioid use disorder, it is very dangerous. The reason is, so say that person takes their morning dose, and 6 to 8 hours passes, and that effect wears off. Like I said, it's the analgesic effect and the euphoric effect that wear off after 6 to 8 hours. So then they take another dose, and then that wears off after 6 to 8 hours. So then they take another dose, and that wears off after 6 to 8 hours. And people can kind of keep dose stacking with methadone, but the scary thing is all of the methadone side effects last for 24 or more hours. The biggest side effect that we're worried about is what? Respiratory depression. Respiratory depression is a risk that can last anywhere between like 24 and like 50 hours in somebody on methadone. So the more and more you dose stack, even though the person kind of feels like, hey, like I'm not even sedated anymore, I'm not even high anymore, that respiratory depression risk is still there, and so they can overdose. So if people are engaged, if they do engage in a clinic, they have to go to the clinic every single day, present every single day, and get their dose. After a certain amount of time, if they're engaging in the programming that's happening at the clinic, if their urine toxicology is coming up negative for all other substances, and it shows that they're really getting into recovery, then the clinic will start saying, okay, now you can have take-home doses. And they'll give take-home doses. Usually it starts with like once a week you come into the clinic to get your take-home doses, and then it goes to once every other week. I mean, that takes months and even years at a time. The most you can get at any one time is 1 month. But that's kind of like the thing to work towards if you're successfully on methadone maintenance. So, like I said, the craving prevention and all the adverse effects can last 24 or more hours. So it's only given once a day, and especially in the very beginning and for the first several months of treatment at the registered clinic. There is no really target dose. Like, it all depends on the person's tolerance and what they tell you they have cravings at. So with methadone, you don't need to know any specific doses other than the fact that it blocks effects of other opioids as long as its dose is above 60 milligrams a day. So the next one is buprenorphine. So the reason that, we have this mu opioid receptor again, and buprenorphine doesn't fit quite as nicely as methadone does into the receptor. This is just to highlight that it's a partial agonist. So it does some activity at the mu opioid receptor, but not as much as something like methadone or heroin or morphine or OxyContin or any of those things. So buprenorphine products, there are a lot of them now. There's a lot that are on the market, but the things to kind of keep in mind are there's buprenorphine that's alone, and the one that the brand name that we typically refer to that one as is Subutex. And then buprenorphine naloxone combination, and that's Suboxone. I do want you guys to know those two brand names just because it's used kind of across the board. The thing is, with a partial mu agonist, if somebody's used to having a full agonist all the time, they're dependent on full agonists, they've been dependent on full agonists for the last 3 years, and you all of a sudden give them a partial agonist, you're bringing them down. You're actually, because you're not getting that effect. And the other thing is that buprenorphine binds so tightly to mu opioid receptors that it will kick off everything else. It binds tighter to mu opioid receptors than any other opioid except for fentanyl. So it kicks off all of the other opioids, and that person actually goes into precipitated withdrawal. So we have to be careful with buprenorphine. It's a really great medication, but we have to make sure that the person's actually starting to experience some signs of withdrawal before we even give the first dose. We want to see them feel a little bit sick. They call it getting sick, is going through withdrawal. Want to feel them getting a little bit sick, or see them, and then you give the first dose, and it kind of makes them actually feel better again. So because of that whole scenario, we like to kind of have those, we call them buprenorphine inductions, be monitored by clinical staff. Some clinics are comfortable giving patients an instruction sheet and giving them a prescription and having them go home and start it on their own. A lot of patients who are really used to the whole world of opioid addiction have already been using buprenorphine products, like kind of here and there, and so they know what happens with it, they know how to use it. But if somebody is really scared, then we can absolutely make sure that they're in the clinic and we're watching them while they get induced. Usually it's very uneventful. So buprenorphine, like methadone, also reduces cravings. If we get to the right dose, it also limits euphoria or high. With buprenorphine, we tend to see that it's better at limiting that high than methadone is. Because of the partial agonist effect, you don't get quite as much response from, for each patient. And there's a maximum dose, which is on the next slide. So after that maximum dose, you can keep taking more and more and more. I had a patient at the VA who took like an entire week's supply in one day, and he was like, nothing happened. I felt nothing. And that just goes to show, one, he's very dependent on opioids. like very physically dependent, has a high tolerance. But after like 32 milligrams a day, even 24 sometimes, you can just keep taking more and more and more, and no additional effect happens because of that partial agonism. So it has that ceiling effect. So because buprenorphine also binds so tightly to the opioid receptors, it will block the effects of all other opioids. Now, if you guys remember from pharmacology, I don't know if you do, but there are two ways that you can kick off something from a receptor. Do you guys remember what those are? So you have an opioid receptor and you have an opioid on it, and you want to do something in order to get that opioid off of that receptor. So first off, what's that called? Competitive inhibition or competitive antagonism. Does that sound familiar at all? Okay. Okay. So, in order to compete, how can you compete? Higher affinity is the one way. What's the other way? Nope. There's another. Concentration, right? So affinity and concentration. So the more you put of the other substance around that receptor starts saying, maybe I don't really like that thing as much anymore. And then it comes off, and then all the other things come back in. So what you can do with buprenorphine and methadone and naltrexone is you can overcome them. But it's very dangerous, and it almost guarantees an opioid overdose. Because what happens is they call it trying to punch through. So they're taking their buprenorphine, they're doing fine on it, and then they get a really wicked craving one day, and they decide to use. And they go and use fentanyl, because fentanyl is the only other thing that has remotely similar affinity for the opioid receptors as buprenorphine does. And they use a bunch of it because they want to punch through. Well, what happens is the fentanyl goes and tries to competitively bind to the opioid receptor. Person uses some, and the buprenorphine is still on the receptor. Maybe there's a little bit of fentanyl floating around it. And then the person uses more because they didn't punch through. And then the buprenorphine eventually comes off. Well, then they have tons of fentanyl in their body, and that binds to all their opioid receptors, and they overdose, and they could die. So it's a big thing to make sure that people have a good understanding of. Most of the time, patients actually really get this stuff. They've been messing with these things for long enough to kind of understand how they work in the body, but it's important that they have an appreciation for just kind of the risks of trying to do those things, like trying to punch through and trying to get high on top of these medications. So the other thing about buprenorphine is that its use is limited to authorized prescribers. So people have to have what's called the Data 2000 waiver in order to be able to prescribe it. The combo product, so Suboxone, buprenorphine, naloxone, is the one that's used almost all of the time. Buprenorphine is typically only used in pregnant patients. We combine it with naloxone because if people were to crush a tablet, dissolve it in water, and then inject it, the naloxone is active, and that throws them into opioid withdrawal. Or it kind of like inactivates whatever buprenorphine is in there. If they were to crush it and snort it, it also will, the naloxone is active in that case, and it will negate the effects of the buprenorphine and may throw them into opioid withdrawal. It's inactive, however, if it's taken as prescribed. So typically, these products are taken sublingually, so underneath the tongue. There are some other products that are taken, they're given buccal versions of, so they're like taken between the cheeks and the gum line. Naloxone has absolutely no activity if you take it that way. It also has no activity if you swallow it. But buprenorphine also has no activity if you swallow it. So it has to be taken underneath the tongue or buccally. The naloxone is there to limit misuse potential. It has absolutely no activity if it's taken as prescribed. It is only there to limit the misuse of it. So other things to consider, buprenorphine is first-line treatment for opioid use disorder. The effective dose is considered to be at least 16 milligrams a day. That's given either once daily or divided, kind of depends on patient and prescriber preference. Maximum dose is 24, but I've seen up to 32 milligrams a day. Again, after these high doses, you don't see much additional effect. The combo product, so that the buprenorphine with the naloxone or the Suboxone, the ratio is 4 to 1. So 4 milligrams of buprenorphine to 1 milligram of naloxone. The lowest dose available of that combo product is 2 milligrams of buprenorphine to a half a milligram of naloxone. And then we talked all about this, it not being active if taken orally. So the next one is naltrexone, which we just talked about, right? It's this opioid antagonist. It blocks the ability of any opioids to bind to opioid receptors. So this one works totally differently than the other two agents. It is a complete opioid blocker. So while it is available in intramuscular formulations and oral formulations, intramuscular is the one that's recommended because of the really big risk for overdose, which we'll talk about on the next slide. Theoretically, naltrexone shouldn't really lower opioid cravings because it's not activating the opioid receptors at all. However, patients actually report that it does, and they tell us that it's the fact that they know if they were to use, there'd be no effect whatsoever. And so that kind of just like reduces the craving that they might have. Naltrexone can protect against opioid overdose. If you use on top of it, you shouldn't get any effect. But just remember that whole theory behind if they try to punch through, if they try to use and overcome the effect of the naltrexone, they can overdose. So that's why it says it can also increase overdose risk for that reason specifically. You have to ensure follow-up is scheduled. You can't just give somebody an injection of Vivitrol and say, like, see you later, have fun finding another Vivitrol provider. First off, there aren't a lot of people who actually give Vivitrol, so that's really tough. And if you've done that, then you've then completely like negated their tolerance. You've lowered their tolerance to almost nothing, and it's been the 7 to 10 days it takes for you to even be able to give the naltrexone, because remember, 7 to 10 days before you can give it without opioids, and then the additional 28 days that they've had the medication in their system. So now they have no tolerance at all, and they have no follow-up schedule, and they have no way to get their next injection. Eventually they're going to know that if they use again, they're going to get high. Well, they might use the same amount that they used before, and if they use the same amount that they used before when they were more opioid tolerant, they could overdose and die. So we talked about the REMS program before, and then, like we said, don't use oral for this reason. So, and this is the reason why it's considered second line for opioid use disorder, because there are these risks associated with really just trying to get somebody onto the medication, and the fact that there's a little bit less treatment engagement. I'm going to try to go through this really quickly so we get out of here on time. So, only use IM for opioid use disorder. The oral formulation has an increased opioid overdose risk, and that's because you have to be abstinent for 7 to 10 days before you start taking it. So if you have to be abstinent, then that ends up lowering your tolerance. So if you do relapse and use within that time period, that could mean an overdose and death. So that's why we always say make sure that the next dose has been scheduled and the person is aware and can get there. So this is just to summarize the different mechanisms of action. So this is a dose response curve, so you get a certain effect depending on the dose. As you increase your dose of methadone, your effect continues to increase. You can just keep going up and you keep getting more and more effect. One of those effects could be an overdose, but you just keep going up and you keep getting more effect. With buprenorphine, imagine that 24 to 32 milligrams is somewhere like here, so that as you increase beyond that, you don't get more effect, because that's a partial agonist. You have a ceiling effect with partial agonists. And then with the antagonists, that's both naltrexone or naloxone. Know that naltrexone is a treatment, naloxone is overdose treatment. Both of those are antagonists, and so you have absolutely no opioid effect at all. For opioid use disorder pharmacotherapy, they tend to measure treatment effectiveness by how long people are able to stay in treatment. So with methadone, it's the kind of, after I did like a review of a whole bunch of papers, it looks like it's about 60% of people stay in treatment at the end of 12 months if they start methadone. It's a little bit less than that for buprenorphine, but with more data, we're starting to see that people are doing a little bit better. Naltrexone is 20 to 50%. So the reason that it's 20 to 50% is they did a study where they did oral naltrexone for opioid use disorder, and only 20% of the people who took the oral formulation stayed on it. And so that's why we don't use it for opioid use disorder. Whereas 50% of the people who were on the intramuscular Vivitrol injection stayed on it at the end of 12 months. If you're on behavioral therapy alone, and this is why we always recommend pharmacotherapy for opioid use disorder, fewer than 20% of people will stay in treatment and be in recovery at the end of 12 months. It's more like 10%. So we know that methadone, or methadone maintenance treatment is what that MMT stands for, has the longest treatment retention. If we were to compare methadone versus buprenorphine, we don't see a difference in positive toxicology screens, and we don't see a difference in self-reported use. So this is why we consider both of them to be basically first-line therapy. And then we know that IM is more effective than oral naltrexone. So when we're talking about people with opioid use disorder and we're talking about treating them, we should be trying to treat them just like we do any other patients with any other chronic diseases. This is just a graph to show you the percentage of patients who relapse with different types of chronic diseases, and you see substance use disorders are pretty comparable to a lot of other common chronic diseases. What we know about opioid use disorder treatments is that pharmacotherapy yields a 30 to 50% reduction in positive toxicology screens. That means people screening positive for other substances that they're using. About a 50% reduction in mortality. This is always the one I use to convince people to start pharmacotherapy when they have opioid use disorder. And half the risk of HIV transmission. So these drugs are amazingly successful and useful for patients. So we have a few questions. I'm just going to pop up the answers on here to get through this. So question 13, the answer is yes for number 1, and it lowers the risk of death by half. And then which medication? Any of the first-line treatments, so buprenorphine or methadone maintenance treatment. So I'm just going to quickly say about pregnancy. When it comes to pregnancy, there's a lot of kind of negative emotions that come up for a lot of patients, or a lot of people treating people with opioid use disorder who are pregnant. Unfortunately, people who are pregnant have opioid use disorder. It happens. And so we have to know what to do, and we have to be able to treat them. So with pregnant patients, things to remember are, if the mother goes through withdrawal, that puts severe risk of death and stillbirth onto the fetus. And so we don't actually want the mother to go through withdrawal. Having them on either methadone or buprenorphine is what needs to happen. If they're stable on one of those medications, do not discontinue them if the person becomes pregnant. Just remember that. Harm reduction is the idea of reducing negative consequences associated with substance use. So that's like the list that I have here, needle exchange programs where people can go and trade in their needles and get clean needles. Naloxone distribution programs to prevent overdose death. The Getting High Right education, which I posted on Blackboard. Anti-stigma initiatives, infectious diseases education, and sometimes pharmacotherapy is viewed as harm reduction. I think it's just viewed as treatment. It's pharmacotherapy, and there's, we don't call insulin harm reduction for diabetes, right? But in some patients, when they're continuing to use other medication or other substances, but they stopped using heroin, sometimes we consider that to be harm reduction if we just have them on the one agent. I'm not going to go crazy into detail about naloxone. I have it under the clinical pearls folder, a guideline on what to do in an opioid overdose situation. I'm probably not going to test you on the exact steps of what to do, but know that naloxone, not naltrexone, is the agent that treats an opioid overdose. Naltrexone is a treatment for opioid use disorder and alcohol use disorder. And then just real quickly to give you these answers. Question 14, answer is C. Question 15, the answer is B. And then question 16, the answer is A. And if you guys have any questions on these, shoot me an email, post them on Blackboard. I'm sorry we went like 2 minutes over. And if you want to get involved, there's some resources that I also posted on the slides.